My name is Michael Battelle, and I am the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. Today, we have a brand new and very special guest, Laurens van Kleef, born in Flushing, the Netherlands. He started medical school at the Erasmus University of Rotterdam. After graduating in 2019, he started as an intern at Albert Schweitzer Hospital in Dordrecht in the internal medicine department. In 2020, he started his PhD program with the hepatology department. He focuses on fatty liver disease in the general population, and he'll begin his postgraduate training in gastroenterology and hepatology by starting as a resident of internal medicine at the Acacia Hospital in Rotterdam. Laurens, you are already credited with at least 29 publications, and I am excited to discuss two of them with you. The first paper is called Fatty Liver Disease is Not Associated with Increased Mortality in the Elderly, a prospective cohort study, prospective being the key, which is great. And your paper was just published in Hepatology in June 2022. Laurens, could you please share more about your research with us?
Thank you, Michael, for the kind invitation. I'm glad that I can share a little bit more about this study and also help on creating awareness for NAFLD. So this study is on fatty liver disease and mortality in the elderly. And check. Yeah, I have nothing to disclose. Just in general, fatty liver disease, is one of the most common chronic liver diseases worldwide, with prevalence over 25%, and thereby affects 1 in 4 people globally. And it is thereby the major cause of cirrhosis and hepatocellular carcinoma, and also it's become one of the leading indications for liver transplantation in the United States. And we know that fatty liver disease is associated with impaired survival, and therefore it's such an important topic. Patients with NAFLD have lower life expectancy of an average of almost 3 years. However, we do not know so much about the mortality in the elderly patients. And the increased mortality risk has created awareness among policymakers and also among experts, and they provided a referral strategy as shown on the left for patients at risk of fatty liver disease or at risk of advanced fatty liver disease. And this algorithm focuses primarily on metabolic dysfunction. And we have shown in a previous study that almost half of the elderly patients do have metabolic cofactors and may require hepatic health assessments according to this guideline. And as mentioned before, there's lack of data on the clinical relevance of fatty liver disease in elderly populations. So therefore, we investigated the relationship between fatty liver disease and mortality in an elderly population. And we used the prospective population cohort, the Rotterdam study. We selected almost 4,000 participants that were at least 65 years old, and we performed abdominal ultrasound and transient elastography in these patients or participants actually. And they were followed up for at least or almost 7 years for all-cause mortality. So a little bit of characteristics of this group. The average age was 75 years, 40% was male, and at least half of them had a metabolic syndrome, indicating the rather poor metabolic health of this group that lead to a fatty liver disease prevalence of 37%. And during the follow-up, almost 800 participants died, which resulted in a mortality rate of 30 per 1,000 person years. So to our main question, that was whether steatosis or fatty liver disease or metabolic dysfunction associated fatty liver disease or non-alcoholic fatty liver disease was associated with all-cause mortality. And when we go to the first results of this study, then you see, let me see where I have the cursor. Oh, it's here. You see the mortality risk of steatosis, NAFLD in these patients. And here you see a hazard rate and a hazard rate of 1 means that it has no impact at all. And this number is pretty close to 1. So the mortality risk of steatosis, MEFILT, and NAFLD, is close to 0. And actually, numbers below 1 indicate lower risk, and numbers above 1 indicate higher risk. And here you see the hazard rates plotted, and everything that is crossing the stippled line means that it is not a significant finding. So the conclusion of this simple age and sex adjusted model is that steatosis or fatty liver disease is not associated with mortality. And when we do a more sophisticated statistical approach, you still see that fatty liver disease is not associated with mortality, because you would have expected it to be on this side instead of the other side. So fatty liver disease is not associated with increased mortality among the elderly. However, that's something not as expected. So we focused on several subgroups. And here again, you see the hazard plot. So for the steatosis or fatty liver disease in the entire population is not associated with mortality, but also in several important subgroups, you see consistent results. So we could not demonstrate a subgroup in which steatosis increased the mortality risk in this elderly population. And in fact, the absence of steatosis in these participants with metabolic dysfunction could potentially be associated with excess mortality, as you can see that the confidence intervals do not cross the stippled line. So patients with metabolic syndrome or hypertension, for example, have a lower risk of mortality when they are part of the elderly population. And these findings that it might be or that is associated with less mortality is consistent with something like the obesity paradox that is known in patients with heart failure. We know that in these populations, the ones that are obese have better survival than patients that are lean with heart failure, and maybe a marker of disease severity rather than that the obesity is protective itself. So we had some secondary exposures and outcomes. We defined the presence of fatty liver disease not only on ultrasound, but also with the fatty liver index. And we added liver stiffness, which is a marker to define the severity of fatty liver disease. We added that to the exposure. And we also checked whether fatty liver disease was associated with cause-specific mortality, mortality within 5 years and mortality beyond 5 years. And I can tell you that NAFLD, regardless the definition, ultrasound or fatty liver index, or with liver stiffness, it was all not associated with all-cause mortality. And similarly, steatosis was not associated with cancer-related mortality, cerebrovascular mortality, and mortality before or after 5 years follow-up. And I want to highlight once again that this is only true in the elderly population. So that brings me to the conclusions and key messages of this study. Among community-dwelling elderly, fatty liver disease was not associated with excess mortality. Moreover, fatty liver disease was consistently not associated with increased mortality risk in clinically relevant subgroups that are often targeted by screening strategies. Next, high liver stiffness did not increase mortality risk in elderly individuals with steatosis. And finally, screening for fatty liver disease is therefore unlikely to improve outcomes among the elderly population.
Well, Laurens, that's really surprising. I'm like stunned a little bit because it wasn't what you would normally expect. In fact, you would think that as people age, the complications from things like fatty liver disease would increase.
That's a good question, Michael. Indeed, you would expect that if you have a longer exposure to the disease, that you have increased mortality risk. However, we also know that most complications of fatty liver disease or liver disease in general occur among those aged between 40 and 60. For example, the average age of patients are transplanted for liver disease or for fatty liver disease is 59 years old, I think, in the United States.
You know what? And also, can you stop sharing so I love to see you on the screen. I wrote down a question while you were presenting. Thank you. That and said, did you look at the same data in the Rotterdam population for age 40 to 60? That's exactly what I was going to ask you.
Yeah, that's a very good question. And we would love to do that. But the Rotterdam study is quite a unique study that focuses on healthy aging. So patients were only eligible to be included when they are, I think, above 60 years old.
Okay.
So we do not have so much data on people younger than 65 years. And we are now extending it, but we don't have the follow-up yet on these.
Okay. So that'll be interesting to see what the next 5 years bring with the same group. So the Rotterdam research group, I guess, is what you would call it, is really unique. And it's how many patients are involved in that in total?
In total, I think more than 10,000 participants have been visited the research center, and most of them visited more than once. So we have follow-up data on these patients as well. And yeah, it's a very valuable cohort for us.
Okay. So I guess my last question too is, in the real world, do you think that this is enough information to be able to make decisions yet, or do we need other studies that are similar to this to evaluate the same circumstances?
Yeah. I would like to see these findings confirmed in other cohorts, of course, but I'm quite confident that we should focus on the presence of fatty liver disease among younger populations, especially because at that age you can still change lifestyle. You can become physical active, and if treatment is available, you can at a younger age and have more potentially benefits than treating at a later stage in life. Yeah.
Okay, wonderful. Thank you so much for sharing that.
Thank you.